It's the WVON Morning Show with Rufus Williams on the Talk of Chicago, 1690 WVON.
Welcome back. Let's keep it moving. I'm happy to have joined me this morning Dr. Josh Eloge. He is the Associate Director of the Women's Board Treatment Research Center, Assistant Professor of Psychiatry and Behavioral Sciences at Rush University Medical Center. Dr. Eloge, good morning and welcome to WVON.
Hey, Rufus. Good morning. I'm really glad to be here. Thanks for having me.
Well, it's good to have you. Let's talk about a lot of things, but why don't we begin with depression? Let's talk about depression. What is it in general, and how is it currently being treated?
Yeah, sure. So, we all, as humans, can have changes in our mood, right? We can all feel down. We can all kind of struggle with motivation. We can all have some sleepless nights. But depression, from a disorder perspective, is when that mood, that persistent feeling of being down, feeling kind of hopeless, really discouraged, lasts for at least a couple weeks at a time, and then it's associated with really not enjoying things that typically you enjoy, not being able to sleep well at night. Your appetite can really get too much, too little. Energy can change. But a few other things that come along with it. And when it lasts for that long and doesn't kind of, just sort of improve with, different circumstances, that's when we start thinking about different disorders of your mood, like major depressive disorder, which is what I was just describing. And that's when we think about ways that we can get in there and try to treat it. There's many ways to treat depression. Certainly things like exercise are effective. Things like psychotherapy, talking with a counselor, can be really helpful. And then I'm a psychiatrist. We have many medications that are effective in depression too. And so those are the typical ways that we treat depression.
Dr. Eloge, is it typical that someone would self-diagnose for depression, or is that discovered by others, by professionals like yourself, or just other people around, or how does it typically come to the front?
Yeah, I would say that a big reason why I got into this field is because while many of us maybe are able to hide some of the pain that we're going through, it becomes obvious to friends and family and people around us. And so I would say communities that we have, being able to identify folks who are not, acting like their usual self because their mood is off, that's the first step, right? And that's a big reason why I'm so excited to be able to talk with you a little bit, just raise a little bit of that awareness so we can keep an eye out for one another. But then, yes, it is a diagnosis that is typically diagnosed with a professional, either a psychiatrist who could do therapy as well as do medications, some other treatments that maybe we'll get a chance to talk about, or a licensed social worker, a master's level psychologist. Those are also people who are able to make these diagnoses.
Let's talk about some of these treatments. What are some of them to deal with depression?
Yeah, so we have been using therapy, talking with a therapist, every week, every couple of weeks, working on specific strategies, what's going on in your life that might be able to help to be able to treat depression, as well as medications. Maybe you've heard of some of these. They're the SSRI, serotonin reuptake inhibitors, things like Prozac or Lexapro or Zoloft. These are the typical first agents that we use, and they help many people. The problem and what my group at Rush really is working on is, unfortunately, so depression affects like 1 in 5 Americans. And then about 1 in a third of those folks don't respond to those typical treatments, like the medications and the therapy. And so this is what we're working on. We're looking at some new ways, knowing what we know now about what we've kind of termed treatment-resistant depression, or people don't respond to the kind of first-line stuff. What might be effective for those people? And so we've looked into lots of different things outside of the typical medications that we use, things like esketamine or Spravato. We've looked at vagus nerve stimulation, which is this procedure that's able to kind of treat in a completely different way. We've been doing some studies with psilocybin, magic mushrooms for depression. That's been really interesting. And then one of our newest ones is it's called the Abbott Transcend trial, and it's looking at deep brain stimulation. So this is something that's been around for a long time in Parkinson's, an essential tremor. But we're looking to see if we can use that same technology to treat, folks who have really struggled with getting any relief from the typical treatments we have.
Let's talk about that a little bit more. Transcend is an acronym, and there's been a study that's been done about that. Spend a little bit more time on that, if you would, Dr. Eloge.
Oh, I'd love to, yeah. So, like I mentioned, this is a deep brain stimulation study. And so what that essentially means is we're working really closely with our neurosurgery colleagues. And they've used this treatment for a really long time in the movement disorder space, like I was talking about with Parkinson's, really some fascinating results. We know that the brain is, electrical and chemical. So we can get in there with different medicines to address the chemistry, but we've had a hard time finding good treatments that address more of the electrical side, and that's exactly what deep brain stimulation is able to do. It's been really fascinating to watch the field over the last 15, 20 years or so really develop in our understanding of what's going on in the brain in our psychiatric disorders, which honestly for a long time we've just really struggled to understand really well. But in the last several decades, years, we've got a better sense of how different parts of the brain are connected and communicate with one another. And this type of thinking of how the brain works has not really shown up terribly well with CT scans or X-rays or MRIs. And so that's part of why we've had such a difficult time recognizing it. But with some of the new developments, we've been able to understand it a little bit more. So based on that idea of how the brain's able to communicate different areas with other parts of the brain, we can use some treatments like a deep brain stimulation and address some of the targets that are really important in mood. So yeah, Transcend is this acronym, treatment-resistant depression, and then the specific area, this is a little technical, but it's the subcallosal cingulate. So it's really important little part in the front of the brain, a little bit above the eyes. That's kind of a highway, like an intersection for different highways that are really important in depression. And so by using that science, we're really excited about finding a specific target that really hits an underlying area that seems to be important in this treatment-resistant depression space. And that's what's really exciting about the study that we have going on. You're right. We have had several studies, small ones, kind of trying to get a sense of what's going on, that has used deep brain stimulation in depression. They've had some pretty good results, which is why we're really excited to go forward with this study. There's I think over a dozen different sites across the country. We're the only one here at Rush in Chicago doing it. But there's, Boston, there's a whole bunch. Out in LA, there's several. Kind of throughout the country, there's many big academic centers. And so we're really excited to try to move the needle forward for folks who haven't received any relief.
So to be clear, this is a 3-year study that's going to evaluate how deep brain stimulation will improve symptoms of depression over time.
Yeah, no, that's exactly right. So the way that this study works is, 3 years. There will be essentially two groups. One will get the stimulation from the beginning, and then the other will wait about a year to have the stimulation turned on. This will give us a chance to really look at the differences between the two groups. And then after that year, everybody has the same stimulation, the same treatment. And then we follow those folks for the next couple of years these studies are certainly looking to see if we can improve the symptoms of depression, especially quality of life, ability to get to work, to hang out with friends and family, do all the things that keep us well. And then quite a bit of extra care is taken to monitor for safety and tolerability for these novel treatments.
Got it. We're talking to Dr. Josh Eloge. He is an associate director of the Women's Board Treatment Research Center and assistant professor of psychiatry and behavioral sciences at Rush University Medical Center. We'll have more with Dr. Eloge talking more about depression when we come back after this.
More of The Morning Show with Rufus Williams coming up on the Talk of Chicago, 1690 WVON.
Welcome back. We're having a conversation about depression with Dr. Josh Eloge. He is the Associate Director, Women's Board Treatment Research Center, Assistant Professor of Psychiatry and Behavioral Sciences at Rush University Medical Center. Dr. Eloge, when you think about the study that's happening with Abbott Transcend, this is the kind of depression pretty much affects anyone. It doesn't matter race, it doesn't matter wealth, it doesn't matter any of these things. How do you determine who's going to be in the study?
You bring up a good point, Rufus. It doesn't discriminate, unfortunately. The disorder can touch so many folks. Like I mentioned, 1 in 5 Americans are affected by depression. If you just look around, I'm surprised in my work how often it is when I have a conversation with you or somebody else, and then inevitably, we're somebody in the family, somebody themselves who I've been talking to, a close friend, have suffered with depression. It's just so common, and it's a big reason why we're looking to find some new treatments that can be effective, because it's not only is it common, it's debilitating. The World Health Organization says that depression is the leading cause of disability worldwide. So just not just these symptoms of the low mood and the struggles with motivation, but also just the ability to work, the ability to hang out with friends and family, like all those good things. So such a desperate need for us to find better treatments.
Indeed, and yeah, that's the question, because when a lot of the studies that have been done have not included everyone in there, and so when we look at our population, the Black population, so often it really doesn't hit on the things that affect us, and this may be disparate within different communities. So, how do you determine who's going to be in this study?
Yeah, so we were. You bring up a really good point. So some of the big studies looking at the prevalence of depression actually suggest that the frequency of depression in the Black community relative to, say, the white community is maybe even better. Maybe there's something that Black folks don't have the same risk factors or something. But in my work, in Chicago, working on the West Side, we you just see, and working with patients, that's just not the case. And I'm really glad that we're bringing this up. There's such a stigma for everybody, but certainly in the Black community related to mental illness. And I think that leads a lot of folks to not seek help or be worried about going to family or talking about it. And so a different survey by the National Alliance of Mental Illness looked at it a little bit differently. And I think this is a little bit more true. I saw that folks from the Black community have a higher incidence of really negative mood, struggles with getting motivated, anxiety, struggles with sleep, many of those symptoms. And so I think that's maybe a little bit more true. This study specifically is really looking at folks who have reached out for help, who have gone to their primary care doc or to a psychiatrist, tried some of those medicines that I mentioned before, some of those first-line antidepressant medicines, have tried therapy, have tried different things and just haven't gotten any better. The depression really hasn't changed. And so it's really those folks that are appropriate for this study in particular. So we're looking at folks who have really, gone through the first several levels of the treatment, but just haven't gotten any better. And this could be, folks from, absolutely, from any kind of walk of life, any race, ethnicity, gender, because we really want to have a big impact. And I think you're bringing up a good point, Rufus, because you're right. So many of the clinical trials, and psychiatry certainly is true. We do many of these studies at Rush. Many of the studies have had an underrepresentation of Black folks. And so we'd really love to see how we can best address the gap in treatment and these outcomes, especially in this community.
Yeah, it's one in recognizing it as you've just done and seeing what we can do to get more people involved in these trials, because it's critically important. I've got a caller who wants to get into the conversation. Andre, good morning and welcome to VON. What's on your mind this morning?
Yes, sir. Good morning to you, Rufus. Good morning to you, Doctor. Thank you for coming on.
Hey, good morning.
I have a question. Yeah, thank you. Good morning to you as well. I have a question to ask you, sir. and this is serious. I'm not being facetious, not joking or nothing. You know, a lot of times we have problems, and I've been around long enough to know that our problems can't get medicated away. What do you say to a person that comes to you and say that they have a fear of losing their home, a fear of losing their job, fear of losing their health care, fear of losing their Social Security due to our political climate? I'd like a serious answer. What do you say to that person?
Oh, that is so real. That is so true. Yes, you're right. There are no magic medicines. And I think you're right. If the environment, if what's going on in politically, like in the country, in the world, or even more locally in your ability to work or be able to provide for food for your family, if those things aren't going well, it's going to be really hard for the treatment to get better. That's a big reason why I think we find that the best treatment, at least at this point, is when we do medications and therapy together. The therapy gives a chance maybe to find some creative solutions to some of those things. But you're right. If there are several things in life that are keeping it hard to be able to feel better, we're going to have a really hard time getting that depression under better control. This is a big reason why I think, it's good for us to be working on these clinical trials and to be thinking about what the next treatment is going to be. But it's a big reason why I really like working at Rush, is that the focus on the social determinants of health, food deserts, housing insecurity, domestic violence, so many of these factors are known to be negative predictors, meaning that they're going to make it harder for depression treatment to work. So, I mean, I agree. What I would say is we need to think about how to treat it from a medical perspective for sure, but we also need more of that environmental support. We need to be able to find some way to be able to take care of ourselves. So, like I mentioned, have food, be able to work, and those things aren't really going to be treated by a medicine per se. Now, if the mood is really making it hard for you even to get out of bed, to get up and get going, to do those things that you got to do to make the situation better, that might be a place for us to think about jumping in with the treatment. But we really need to get it needs to be a comprehensive treatment, and that's why I think seeing either a psychiatrist or a therapist or a primary care doc and being able to get kind of a comprehensive look, not just at these symptoms that I was mentioning before, but also what's going on at home, what's going on in your relationships, what's going on with work. That's really going to be the best way to find a way to go forward.
Andre, thank you for your call and engaging. Dr. Eloge, thank you so much for the work that you're doing there at Rush and for coming on and talking to us about these studies, because we need to know what's happening, and appreciate you coming on and sharing it with us.
Oh my gosh, it's my absolute pleasure. Thank you so much for having me, Rufus. And I really enjoyed being able to talk with you.
Thank you. Be well.
All right.
Let's find out what's going on in Black Information News and the headlines. Be back with more for you right after this.